Very good afternoon, and thank you, sir, for inviting me about this discussion. So, I will be presenting briefly about simplified approach to management of hepatitis B and C virus. So, I will be discussing the presentation in the outline, case-based presentation and approach to case of hepatitis B virus, special population in hepatitis B, and approach to patients with hepatitis C virus. This is already discussed by Dr. Ekta. There are various markers of hepatitis B virus. Hepatitis B virus DNA is the genetic material of the virus. Surface antigen and E antigen is the marker of active replication, whereas anti-HBs more than 10 is suggestive of protection from hepatitis B virus. I will not go much in the replication of hepatitis B virus. This is the hepatitis B virus virome that enters in the hepatocyte through the anti-CP receptor. This incorporates with the host DNA or may convert to the CCC DNA, and this transcript this goes to reverse transcription. This goes to synthesis of multiple RNAs, and this may go to reverse transcription and synthesize again the hepatitis B virus DNA, or this goes to the endoplasmic reticulum and can be secreted as hepatitis B virus surface antigen and hepatitis B virus DNA in the circulation that infect other naive cells. So, what is the natural course of hepatitis B virus? Whether it's acute or chronic, this all depends on mode of transmission. When the transmission is perinatal from mother to child, this mainly goes 90% subjects will be chronic, will carry the infection in the chronic state. This is the most common mode of transmission in the India, and when the transmission of hepatitis B virus occurs in the infancy or late childhood, majority of the subjects will clear the virus in around 95% of the patients, and 5% only will carry the virus in the chronic state. Natural history of hepatitis B virus is already discussed by Dr. Ekta, and EGL guideline in 2018 they reclassified the stages of hepatitis B virus mainly based on E antigen positivity and negativity, DNA titers, and presence of necroinflammation in the liver based on ALT levels. So coming to first case, a 43-year-old male subject who recently donated the blood, and the blood investigation found to have HBs antigen positive. His further evaluation in the 2 visits showed normal ALT and DNA titers of 6 logs with E antigen positive. So, what is the diagnosis of this case? Previously, such patients were defined as inactive carrier but nowadays these patients are redefined, reclassified as incidentally detected asymptomatic hepatitis B virus positive subjects. So, this is the different entity as compared to inactive carrier, because many of these patients may have significant fibrosis, and also there is risk of occurrence of SCC and progression to cirrhosis. So, this is basically state of chronicity of hepatitis B virus. As of now, no guideline in this state recommend the treatment for this population, and majority of the patient we advise to follow up and with close monitoring. Majority of the patients behave well, but not all. Coming to another scenario, a 45-year-old male subject who presented with some non-specific symptoms like fatigue, abdominal discomfort. His investigation showed high ALT 2 times above the normal limit. Further evaluation showed HBs antigen positive and E antigen positive with high DNA titers and significant fibrosis, liver stiffness 8.8. So, these patients are ideal candidate for start of antiviral treatment and may benefit with antiviral treatment. So, how to react with a positive test for hepatitis B virus antigen? First, rapid diagnostic test may be less sensitive or less specific. So, we must verify the investigation with confirmation by the ELISA, and we should assess the state of ongoing necroinflammation by doing ALT levels and fibrosis assessment as per the national guideline. Non-invasive fibrosis assessment like APRI, FIB4 and FibroScan if this is available. Invasive fibrosis assessment is not required and is the basically tool for research purpose that can be done in the patient with high ALT with liver stiffness in between 7.4 to 9.4, in patient with normal ALT and liver stiffness in between 6 to 9 kilopascals. So, the bedside tool to assess the significant fibrosis, these are the APRI. The APRI is it can be done easily. The online calculator is available for APRI and FIB4. With the help of AST and platelet, APRI score more than 2 is suggestive of cirrhosis. So, these patients require treatment. APRI score more than 1.5 also suggests of significant fibrosis and patients should be treated with antiviral. Similarly, FIB4 score, this also can be calculated on OPD basis with the help of online calculator with the parameters age, AST and platelet and ALT levels. So, FIB4 score more than 3.25 suggestive of cirrhosis and more than 1.45 suggestive of significant fibrosis. But there is drawback with these parameters because AST, ALT levels can be varied and can be affected by subtle illnesses like some viral illnesses, obesity. In these patients, there could be some component of non-alcoholic steatohepatitis. This also can be affected by drugs, and that can cause drug-induced liver injury. So, decision of treatment for hepatitis B virus depends on multiple parameters. First is stage of fibrosis, whether there is significant fibrosis is present or not. If there is cirrhosis, and level of liver enzymes and hepatitis B virus DNA level. So, as per the guideline and national program, if the patient had E antigen positive with ALT levels more than 2 times with significantly high DNA level, these patients should be treated with antiviral treatment. Patient with a normal ALT and E antigen positive subject with normal ALT and despite of high DNA titers, they should be monitored and upfront treatment is not required in this patient because of less progression to advanced disease and less liver related events in this patient. In the gray zone, when the ALT levels are mildly elevated and DNA titers are high, so these patients also do not require upfront treatment and these should be followed and can be started treatment on further deterioration. Similarly, patient with HBe antigen negative, the HBe antigen negative subjects can have advanced fibrosis or significant liver disease even at the low DNA titer levels like up to 2000. So, such patient with high ALT levels and DNA titer more than 2000, they should be started on treatment. Patient with low ALT and moderate elevation of the DNA, they should be followed and should not be started on antiviral upfront. So, what is the concept of treatment of hepatitis B virus? This is basically to induce the immune response of the host because antivirals do not clear the hepatitis B virus. This is immune response that clears the hepatitis B virus. This immune response there is increase of the CD8 cells that helps to clear the virus and may lead to loss of E antigen and loss of surface antigen also. So, how the virus clear from the body? So, you can see in the subjects who had acute hepatitis B virus infection. So, in the these subjects are never exposed to hepatitis B virus DNA or surface antigen. So, their immune cells are active against hepatitis B virus and there is high level of hepatitis B virus specific CD8 cells. So, these specific CD8 cells helps to clear the infected hepatocytes by apoptosis or secretion of interferon that eliminates the hepatitis B virus replication. On the other hand, in subjects with chronic hepatitis B virus infection, these CD8 cells get exhausted and they do not respond to the infected hepatocytes or hepatitis B virus DNA, and there is less clearance of the hepatocytes by apoptosis or interferon. So, why to treat hepatitis B virus infection? Treatment halts the disease progression. Also, this causes reversal of advanced fibrosis, and this may lead to recompensation of the liver disease in patient with decompensated cirrhosis. prevents the occurrence or recurrence of hepatocellular cancer, and it also prevents the transmission of hepatitis B virus from one to another individual. So this is the study that showed that patients who were treated with antiviral treatment, they had reduced risk of SCC and liver related events as compared to patient who was not treated. So this study also suggests that patient who received antiviral treatment course, even in the decompensated state, the patient who received antiviral treatment had less mortality as compared to patient who didn't receive antiviral treatment. The goal of the treatment of hepatitis B virus, the ultimate goal is the absolute cure, that is defined as undetectable hepatitis B virus DNA, loss of surface antigen, and presence of anti-HBs titer more than 10 international unit per liter. But this is difficult to achieve and even not possible in the real life practice. So the clinical or functional cure is also accepted goal of hepatitis B virus treatment. This is defined as loss of hepatitis B virus DNA and loss of surface antigen, undetectable DNA and surface antigen with variable presence of anti-HBs titer. So why these patients are also benefited with the treatment? Because there is less risk of progression of the hepatitis B related liver disease and less occurrence of the SCC. So what are the drugs for the treatment of hepatitis B virus? Mainly now we are using nucleotide and nucleoside reverse transcriptase inhibitors, that is entecavir and tenofovir. These are highly potent drug with less risk of resistance. Previously used drugs like lamivudine, telbudin and adifovir, all these were moderately potent drugs with high risk of resistance. So which drug we should use for antiviral in patient with hepatitis B virus? When they need, there is indication of treatment for hepatitis B virus. If the patient is treatment naive, at any age we can use tenofovir or entecavir, but we should use tenofovir in the subjects who are more than 60 years of age, because tenofovir may affect their bone density and there is increased risk of fractures in such subjects. And also this can cause decrease in the creatinine clearance. So as subjects who has creatinine clearance less than 60, they should be cautiously use of tenofovir, and preferably we can use entecavir in such subjects. So where in the patient with pregnant women, the tenofovir is the only drug that is safety is validated in pregnant population. Entecavir safety is not validated in the larger studies. The subjects who had tenofovir resistant, this is rarely seen. If the subjects are lamivudine naive, we can switch over to entecavir. If the subjects are already exposed to lamivudine, there is also higher risk of entecavir. So in these subjects, we should add entecavir over the tenofovir. And on the other hand, patient who already received some sort of treatment, preferably lamivudine, they were exposed to lamivudine, or there is risk of entecavir resistance, they should be switched over to tenofovir. So dose of tenofovir is 300 milligram once a day. Entecavir in compensated cirrhosis is 0.5 milligram once a day. In patient with decompensated liver disease, it should be given at 1 milligram once a day. And tenofovir alphenamide, this is highly gets concentrated into the hepatocyte, so this required less dose of the tenofovir, that is 25 milligram once in a day. But we cannot leave all the patients who had persistently normal ALT, because few of the patients may progress to fibrosis, and these patients may develop cirrhosis or occurrence of SCC. Like this study from GB Pan, they showed that patient who had persistently normal ALT, there is risk of progression to the fibrosis around 13.8 to 39% of the patients. Another study showed that patient who had persistently normal ALT but high DNA, there was increased risk of hepatocellular carcinoma as compared to patient in this population. And this Korean study showed that patient who had untreated and had persistently normal ALT, there is risk of SCC and liver related deaths as compared to patient who received antiviral treatment for hepatitis B virus. So what should be the approach for patient with persistently normal ALT? These patients should be closely followed for 6 monthly at the interval of 6 monthly with regular DNA and ALT and fibrosis assessment, and also for the tumor screening. And requirement of the treatment should be decided by fibrosis rather than ALT levels. One should start on the antiviral treatment if there is family history of cirrhosis or SCC, or there is long exposure of the hepatitis B virus, like the patient whose age is more than 40 years. How to assess the response of the treatment for hepatitis B virus infection? Once we the treatment, when it is indicated, there should be at least 2 log decline of the DNA titers within 3 months of the treatment, and it should go undetectable at 6 months of the starting of the treatment, and ALT should be normalized. So in this scenario, the patient should be regularly followed at the interval of 6 months to 1 year with regular DNA, ALT and creatinine assessment, and bone density assessment after 1 year if the patient is on tenofovir. Failure to achieve the adequate response, that is less than 1 log decline or persistently high levels of ALT, we should check. This rarely occurs with current antivirals like tenofovir and entecavir. Then we should check the compliance. If the compliance is adequate and patient is on lamivudine, then we should switch over to tenofovir or entecavir. With entecavir, the patient should be switched over to tenofovir. Tumor risk assessment is very important in patient with hepatitis B virus infection, and we have multiple tools. The validated tools are REACH-B score, AMREACH-B and PAGE-B score. Out of these, AMREACH-B is validated in some Asian population, and this also had liver stiffness measurement. The negative predictive value, when the scores are low, less than 5, 10 and less than 9, negative predictive value of occurrence of SCC at 5 years of follow-up is very good, around 96 to 100% if the scores are low. So how long we should continue the treatment for hepatitis B virus? In the patient with cirrhosis and decompensated cirrhosis, lifelong treatment is required. This also depends on the type of therapy. In the context of non-cirrhotic patient with interferon, that is rarely used now. This is the definitive duration therapy, maximum up to 48 weeks. With nukes like entecavir or tenofovir, the guideline recommends that at least 12 months of consolidated phase is after loss of E antigen is required for the effective management of hepatitis B virus. And there are specific population, like there is high risk of hepatitis B virus reactivation, particularly in the patient who are on some sort of immune suppression, like patient on bone marrow transplantation, or patient who are going for some biologics. There are at least risk of 1 to 10% risk of hepatitis B virus relapse. So in such patient, the upfront of antiviral should be started in patient who are undergoing bone marrow transplantation or who are undergoing to receive steroids with the presence of HBs antigen positive. In case of HBs antigen negative and anti-HBC total positive patients who are particularly going for biologic, they should be started upfrontly for antivirals. Coming to the pregnancy is well known for flares of hepatitis B virus, especially after the delivery during the postpartum period. And also there is a risk of vertical transmission of the hepatitis B virus from mother to child, and this vertical transmission leads around 95% of the patient to the chronicity. So this can be prevented by effective antiviral, that is tenofovir, during the pregnancy. That should be started at 24 to 28 weeks if the DNA titer is more than 20,000. So in case of pregnant female, we should identify whether there is indication of antiviral there is maternal indication of the antiviral, like if there is presence of cirrhosis or persistently high elevated of ALT, then we should start the antiviral and this should be continued. If there is no maternal indication and the antiviral we require is for the mother to child to prevent is mother to child transmission, then we should start the antiviral at the 24 to 28 weeks of pregnancy in the subjects who had high DNA titers, and we can discontinue after 4 months after the delivery. Another measures to be taken for the newborn baby is to give single dose of hepatitis B virus immunoglobulin and to vaccinate the child, and in some resource constrained states, if the immunoglobulin is not available, the vaccination alone can prevent around 97% of infection of mother to child transmission. Coming to co-infection of hepatitis B and C infection, usually hepatitis C virus suppress the hepatitis B virus replication. So once we start the treatment of hepatitis C virus, like all the subjects with hepatitis C virus RNA positivity, they should undergo to treatment for hepatitis C virus. So once the RNA gets suppressed because of antivirals for hepatitis C virus, the DNA levels of hepatitis B virus goes up, and there may be risk of flare of hepatitis B virus that may lead to fulminant liver failure, mortality, and even requirement of liver transplant. So guideline recommends that all subjects who with the hepatitis B and C virus co-infection undergoing for DA treatment for hepatitis C virus, they should be started for antiviral for hepatitis B virus at least 7 days prior to initiation of DA, and to be continued 12 weeks post DA treatment to prevent the flare of hepatitis B virus. So what about a healthcare worker? If someone diagnosed as hepatitis B virus, usually they are isolated, but they should not be isolated. And subjects, CDC recommends that subjects whose DNA titer is high, they should be, and they are enrolled in the high risk exposure procedure, they should be started on antiviral treatment irrespective of the ALT levels and significant fibrosis. So coming to hepatitis C virus infection, as we already discussed that hepatitis C virus infection acute occurs only in around 15 to 25% of the subjects, and mainly they carry the chronic infection for lifelong and may go to progress to cirrhosis in around 20 to 30% of the patients, may develop decompensation or had occurrence of SCC. Previously, there were only treatment available for hepatitis C virus was interferon. That was quite cumbersome to give the interferon, and efficacy was also not good for in the case of interferon. Now, since 2016, we have DAs in India, and also included in our national programs like sofosbuvir, declatasvir, and velpatasvir. So, type of regimen in all the subjects with hepatitis C virus infection with RNA positivity, they should start on DNA treatment or DA treatment, and the regimen of DA should be decided on presence of cirrhosis or non-cirrhotic or compensated or decompensated cirrhosis. As per the national guideline, patient without cirrhosis, they can be treated with effectively can be treated with sofosbuvir and declatasvir for 12 weeks. Patient with compensated cirrhosis, preferably sofosbuvir and velpatasvir for 12 weeks. Patient with decompensated cirrhosis, we can add ribavirin, dose dependent weight based dose of ribavirin for 12 weeks. So, genotype 3 is relatively difficult to treat. Sofosbuvir and ledaprasvir are effective against genotype 1, 4, 5, and 6. Sofosbuvir velpatasvir is also is a pan-genotypic drug, and Decla is also a pan-genotypic drug, but is not effective against genotype 1 and genotype 4. Monitoring of hepatitis C virus on treatment. Previously, we were doing hepatitis C virus RNA frequently, but as per current recommendation of the national program, There is no need of doing hepatitis C virus RNA frequently. We directly do RNA testing 12 weeks after completion of the DA therapy. The benefit of SVR in hepatitis C virus, there is decreased transmission from one to another individual. There is improved clinical outcome in patient with liver disease, like there is decreased risk of cirrhosis, decreased risk of decompensation, occurrence of SCC, and requirement of liver transplant. Out of context of the national program, but patient who had treatment failure with the DA for hepatitis C virus, they can one can try in the previous regimen if there was if interferon ribavirin was used. Now we can try with DAs of Velpa, and if the previous regimen was sofosbuvir and declatasvir, one can try with sofosbuvir, velpatasvir and voxilaprevir for 12 weeks. If the failure was with sofosbuvir and velpatasvir, again one can try with sof velpa and voxilaprevir. So carry on message. Treat hepatitis B virus if DNA is more than 2000 international unit plus high level of ALT or there is presence of cirrhosis. First line drugs of treatment of hepatitis B virus is tenofovir or entecavir. Vaccinate the family contacts of hepatitis B virus patient after exclusion of hepatitis B virus infection in those. To prevent mother to child transmission, one should start the antiviral in the mother after 24 weeks of the pregnancy if the DNA titers are more than 20,000, and give the hepatitis B virus immune globulin to the newborn baby, and do the routine vaccination within 12 hours after the birth with who are the babies who are born to hepatitis B virus positive mothers. Thank you.